My name is Harlan Beckley. I am Executive Director of the Shepherd Higher Education Consortium on Poverty, and I'm happy to convene this symposium, our fourth since the inception of the consortium. And I want to begin with a thank you to Virginia Military Institute for much support, including where you're sitting right now and all these wonderful facilities that we're going to enjoy today, but also including other support for our program and also including just being wonderful hosts for us. So I'm going to thank Professor Megan Harrell from VMI, and she's going to come to welcome you to the post.
Good afternoon. I'm honored to be hosting you as part of VMI's outreach programs. We are thrilled that you are here today. One thing you may know about VMI, it's the nation's first state-funded military school. You probably know that our cadets or our students have to show excellence in academics, athletics, and leaderships. But what you may not know comes from part of our mission statement. And the mission statement's long. I'm only going to read the very first part of it, but I'd like you to hear this. It is the mission of the Virginia Military Institute to produce educated, honorable men and women prepared for the varied work of civil life, imbued with love of learning, confidence in the functions and attitudes of leadership, possessing a high sense of public service. And that is what brings us here today. VMI is honored to host the closing conference for the Shepherd Consortium and all of you who have the high sense of public service. Thank you very much and welcome to VMI.
So it's my privilege to introduce our speakers for today. And in introducing the speakers, I don't want to go back and repeat everything that you can read and have read, I hope, on web pages about their biographies. But I want to say something a little bit more personal, and some of it's more recent than the biographies that are published on the website. And I also don't want to take a whole lot of time away from their opportunity to speak with you. So I'll be relatively brief. Elaine Waxman. My connection with Elaine begins with a connection with James Ziliak. And I had said a fellow economist, but I've been corrected on that, as she studied economics at Chicago School, where she said she was inoculated from the usual brand of economics there. Jennifer and David will be glad to hear that. And her degree is in policy analysis and social work, as I understand it. But Jim is from the University of Kentucky, and one of the reasons we are having this symposium on this theme is because of an article he wrote in the Future of Children on childhood food security. And that led me to think this is a theme that to which we need to give attention, especially with the Shepherd Consortium. And so that led from one thing to another, and I asked Jim who would be a good person to come and talk to us from the perspective of a policy analyst about food and nutrition and children's health. And he, without hesitation, recommended that I invite Elaine, who at the time was the vice president at Feeding America and had gained a great deal of respect for her work in mapping food insecurity in the U.S. And I will mention one item that's mentioned on the biography. She is the author of Hunger in America 2014, which is a comprehensive book about food insecurity and hunger in the U.S. But you need to know what's not posted on the bio as well. Elaine's work not only impressed Jim Ziliak, it also led to an invitation from the Urban Institute in Washington, D.C. to join it as a senior fellow at its Income and Benefits Policy Center. Elaine accepted that invitation, and she's now with the Urban Institute. But you should not conclude that she has joined the establishment inside the Beltway. She resides in Chicago and travels to Washington on occasion, and Chicago is the place where she received, remember, her graduate degrees. So she remains Mr. Stroud, a Chicagoan. I won't repeat her long list of publications. You can look at that yourself. But I want you to know that Elaine, like the other speakers with us for the symposium, has been very helpful in helping us choose the video last night, helping us to frame the issues of the symposium, and I am grateful for that. I think that's probably one of the reasons, that kind of inclination that Elaine has, is probably one of the reasons she's become the kind of policy analyst who is interested in food insecurity and nutrition and diminishing hunger in the U.S. She will speak to us today on the topic, the evolution of food security as a public health issue. Thank you, Elaine, for being here.
Good afternoon. I barely make it over this podium, so I'm probably going to walk around a little bit. First, I wanted to say thank you. And obviously, I want to thank you for having me to join you at the consortium. But also, thank you so much for the work you did this summer. I had the chance to sit anonymously in the back of the room last night and listen to your comments after the video. And it was just very inspiring to hear about the different organizations that you had been with. And also the really keen insights that you had picked up. You picked up on some really interesting things that were absent in the video, that were under discussed. So it was really a pleasure to hear you, and I'm grateful, just grateful for your work. So I'm going to tell you a little story about this picture that's on here. I just threw this on here last night. So I worked in Washington this week, and I went to the American History Museum yesterday, one of the Smithsonian's, and they have a big exhibit right now on food. And so, of course, I had to go. And first of all, they have Julia Child's actual kitchen that she apparently donated. And they have, like, Hello Kitty bento boxes and, like, everything you can think of. So I wasn't necessarily expecting them to deal with social issues, but I was sort of pleasantly surprised because there were some things about migrant workers there. There were some other things about the development of processed foods and the rise of the change in eating. But in a little tiny corner on a section called Food for the People, which was mostly about counterculture in Berkeley and soul food, there was one set of pictures about food insecurity. They didn't even actually really call it that. And what's interesting was the two examples they had were associated with the Black Panther movement. If you think back to the 60s, you may or may not know this history, but the Black Panthers were very instrumental in actually providing a fair amount of free food, free early breakfasts for kids, really trying to address some of the issues in the community. But I thought it was fascinating that an entire exhibit devoted to food, you didn't hear the words food insecurity, despite the fact there are 49 million Americans who struggle with food insecurity. You didn't see anything about food banking, right? Food banks in this country serve 46.5 million Americans in a year. And the one way we talked about it was in a very specialized, and some would argue political manner. So I wanted to include this so I could tell you that story, because I think it reflects a little bit about sort of the hidden epidemic that we don't talk about in this country, and that I hope we engage in a conversation about today. So just to get started, I know we have some mic folks here, and because they're filming, it's great if you can actually shout into the mic, but if not, I will repeat what you say. You guys are very insightful, so put that away for a minute. Just think like the general public, if you can, and tell me what you think comes to mind for people when I say hunger in America. What does that look like? There are no wrong answers. Appalachia. Sorry? Appalachia. Excellent. You know, it was rediscovered in Appalachia, right, in the 60s. It's just not far from here. I'm actually from Kentucky. My mom's family is from eastern Kentucky. So what many people knew in the evolution of the war on poverty was white rural hunger, right? That's what it looked like. What else? Homeless people. Oh, thank you. Actually, only 1 in 10 people who use the services of the food banking network are homeless. The vast majority of people are stably housed in some form or another. But that's what we think of, right? And when we think soup kitchen, we often think of people who use those, right? What else? Children. Because we like to talk about kids, right? It's easier to talk about kids. It's not their fault. We're concerned about their development. We know it's the future. But what's interesting is you'll not hear me talk that much about child food insecurity per se today, because I would argue that children aren't food insecure in a vacuum, right? They live in households. They live with adults who are food insecure and actually often try to shield them from food insecurity. Single people without children, you know, they actually may be non-custodial parents. Grandparents, seniors who are food insecure may live in multi-generational households. And in fact, grandparents and seniors who live with children, the children do better on food insecurity measures, the grandparents do worse because they're there trying to support the children. So at the end, when we talk about children and health and nutrition, we're really talking about the whole community. All right, a couple more. Yes?
Obesity.
Obesity. Yes. So that's really hard for people to wrap their heads around. First of all, the research on the connections between food insecurity and obesity is not clear. There seems to be some association, particularly for women, but not necessarily for men. But what we do know is that it happens in the same communities, right? It happens often in the same households, and those things can exist in the same person. And you can't struggle with one set of food-related issues without dealing with the other. And this has been, I think, a big mistake that both the community addressing obesity and the community that was focused on food insecurity made, in that we stayed on two separate sides of the discussion for a long time for various reasons, and didn't have that interconnected discussion, which makes no sense because these communities are dealing with both of those things. But it's very hard for the average American, if they were to walk by a food pantry and see someone who is obviously obese, what are they going to say? They're not hungry. They don't need any food. And not give any thought to how that might have happened, how their food insecurity might have actually created certain behaviors, certain conditions, maybe even changed their biology in a way that facilitated that obesity. And that makes it super hard to actually address your obesity, right? As we'll talk about. Okay, anything else? Yes, back.
Immigrants and minorities.
Immigrants and minorities. Right. The only individuals in the Smithsonian exhibit were African American, urban residents, right? And we do know that African Americans and Latinos and immigrants are at higher risk for food insecurity than others. But actually the majority of food insecure people in America are white. So, thank you very much. All right, so as I mentioned, this issue that sort of hides in pockets is really very pervasive. 1 in 6 Americans struggle with food insecurity. That's 49 million people in the most recent measure that we had. And for kids, it's 16 million. Proportionally, that's 1 in 5. Somebody mentioned last night the WIC program. I know that came up during the discussion after the video. Did you know that WIC actually serves 50% of infants born in the United States? So WIC, you can actually receive up until about 185% of the federal poverty level, but that's not a lot of money. But that means 50% of babies born in the United States are pretty vulnerable to food insecurity. And it happens in every county in the United States, even the most exclusive, most high income, because there are always people in those communities who provide services to other people in those communities, right? So when you think food insecurity, you don't think the school crossing guard at the exclusive school. You don't think the person who did your dry cleaning. You're probably not thinking about the domestic employees who come to wealthy neighborhoods. But in fact, many of those people live nearby because, as somebody mentioned last night, transportation is a big issue. So if you can get employment, the closer you live, the better. What that means is it's in every community. This is actually a snapshot from a website that you can visit. You can see it at feedingamerica.org. And it actually provides food insecurity estimates for every county in the United States. So I hope tonight you go back and look for the county that you worked in this summer. I hope you go home and look at your home county or where you may have lived. It will tell you the number of food insecurity, it will tell you the rate, it will tell you income. What's interesting to know is that about a quarter of the food insecure in the United States actually earn incomes above 185% of federal poverty level, which means they're not eligible for federal nutrition programs, whether that be free and reduced price school lunch or WIC or school breakfast or any of these other things. And so we, I think, became more aware of this during the recession, that people were struggling, that people might have come across a foreclosure. But back to that fact about WIC and the percentage of births, there are a lot of folks who are kind of hovering around that line, and potentially one emergency room visit, one car breakdown, one divorce, death in the family away from struggling with food insecurity. So I just want to quickly talk about how we actually measure food insecurity in this country, because we have actually a very specific set of metrics, and the current population survey every year surveys a nationally representative sample of the US, and that's where we get that 49 million estimate. It's we have two sorts of ways of characterizing it. One is food insecure, and one is very low food security. And there are some important distinctions that I think are really helpful to keep in your mind when we think about how to answer somebody who says, well, you know, those people really aren't hungry. They don't manage their resources very well, et cetera, et cetera. First of all, low food security means that these are households that had difficulty at some time in the prior year providing enough food for everyone in their household to have an active, healthy lifestyle. And what it means, though, is it might not mean that they're actually skipping meals, but that they're reducing the variety of what they eat. You're college students, you can relate to that, right? Not a lot of variety, poor quality, stretching supplies, watering things down, not a great deal of anxiety about how to make things work. And then very low food security, which thankfully is less common in the United States, but still affects millions of people, is where you actually see disruption in intake. So really drastically cutting the size of meals or actually missing meals. And here's some of the questions that you ask. So for example, the food that we bought just didn't last and we didn't have money to get more. Was that often true, sometimes true, or never true? Or we couldn't afford to eat balanced meals. I don't love that question because I'm not sure people actually know what balanced meals are. Americans tend to think that balanced meals mean you have to have meat, right? But right? It's people's estimation, I think, of whether they know that they're able to get a variety of foods. And then more to the point of very low food security. In the last 12 months, did you or other adults in the household ever cut the size of your meals or skip meals because there wasn't enough money for food? And so if you answer affirmatively on 3 or more of this scale, we classify you as low food security and very low if you answer to 6 or more. So why do we care? Well, because food insecurity, either kind, frankly, you don't have to have the most severe to see health impacts of food insecurity, has multiple health implications, right? Low birth weight, birth defects, iron deficient anemia, that has something to do with cognitive development, cognitive delay, just not being very healthy, colds, stomach aches, more frequent trips to the hospital. Again, poor educational outcomes. You can't think when you haven't eaten, right? If you ever fasted for an entire day, for religious reasons, I fast a couple of times a year, and I don't allow myself to drive by the afternoon because I'm so not functional. And you know, there are adults and kids who sort of deal with that all the time, and your head is just fuzzy, and it's really hard to focus. Mental health. It's a great deal of stress to put on young kids. And they feel the stress that is going on in the household too. We know that kids often, in fact, try to participate in the coping strategies, particularly teenagers. I'm working on a really interesting new study on teens and food insecurity, and it's clear that teenagers really feel the burden. They often participate in household food management. They're often using SNAP benefits on behalf of the family. They're looking after younger brothers and sisters. That's a lot of weight for young people to carry. And then finally, we see that it's associated with increased healthcare utilization for all the reasons that you can imagine. And adults, poor health status, right? Obesity, particularly in women. It can coexist, but there seems to be particularly an association there. Diet-related chronic disease, and we'll come back to this in a few minutes. There's some growing evidence that suggests that people who are food insecure are more likely to develop diabetes. And then clearly when they have it, they're not very well positioned to manage it because one of the key strategies for managing diabetes is how you eat and when you eat, right? Heart disease and depression, and this gets right back to kids because we know there's a fair amount of literature that suggests a relationship between food insecurity and maternal depression. And that can go both ways, right? You can imagine as a mom, if I know I'm not really able to do the basics for my kids, that's incredibly stressful, right? But it also might work the other way. I am struggling with depression, and it's really hard for me to be able to work or take care of my kids, et cetera. Maybe it becomes a cycle. So these are very, very profound health issues, potentially affecting 49 million of our Americans. It may have affected some of you in this room. So, why do we not talk about hunger as health? Because we don't typically in this country very much. So I'm going to take you on an insanely rapid tour of about 200 years of social welfare policy, just to sort of set that frame. So I think the most important thing to take away from this is from the very beginning of social welfare responses in the United States, food assistance has been very tied up with a lot of other issues about who's deserving or undeserving of help, right? We have a particular fascination in this country with the deserving poor and who's not worthy of assistance. Beliefs about what hunger looks like, you helped with that, right? And strategies for managing agricultural surplus, agricultural policies, strategies we want to use to support the free market economy. So often those kinds of policies drive what we choose to do about food insecurity. And that goes back way back. So have you ever heard that term outdoor relief? Anybody from history class remember that? Okay, so back in the day, and I'm talking like, 1800s and even before, there were sort of two routes. One was the poorhouse, where you went if you couldn't take care of yourself or your family. And they really created that as a deterrent for the able-bodied poor because they wanted to make it really bad so you wouldn't want to go, so that you would work. Overlooking the fact that work was incredibly unstable and poorly compensated in our early economies. But that was the sort of philosophy behind it, right? The other route was outdoor relief, and this was the idea that maybe it's better for you to stay in the community, it's better for a family to stay together, so we're going to assess whether we think you're shirking, whether you're worthy, and we can provide some assistance to you, and that's usually in the form of food because we don't think you'll use that in an inappropriate way. If we gave you cash, you might be doing things with it we don't want you to do, right? So from the very earliest times, we had this, what we call scientific charity, which actually gave rise, this is sort of the early antecedents of social work, right? Friendly visitors, this is another word you'll hear, that went and visited the poor, and on behalf of the county relief would determine whether or not people were deserving. Usually a mom and a bunch of kids would be deserving. If there's a man in the house, they're going to wonder why he wasn't working. It's better if the mom is widowed and not deserted, right? Or non-marital childbearing, right? So these were all in the very earliest stages of our ways of responding to people who were struggling, very much tied up in judgment about whether or not people deserved help. Skip forward to the Great Depression. We've covered a fair amount of time there. This is the first time we've had really profound, at least in the industrial economy, really profound widespread unemployment. It can't be ignored, right? But one of the major preoccupations, in addition to the fact that a lot of people needed help, was that the farm economy was in a huge jam. There was no resources for people to buy a lot of what was being produced. Farmers were struggling. And so much of the relief programs came about based on trying to buy up agricultural surplus and then in turn giving it through relief programs. So that started a very early pattern that actually continues today in a program called the Emergency Food Assistance Program, or TFAP. So, and again, we see this theme of food was in-kind relief, meaning, not cash. And so that was particularly comfortable for people to give out so that it wouldn't potentially lessen your will to work. All right, food stamps actually began as a pilot during the Great Depression, but as things improved, kind of fell by the wayside. But it was interesting to know that the early design was you actually had to buy a certain number of stamps to prove that you were using your own resources, and then you got some bonus stamps at 50 cents on the dollar for which you could then buy agricultural surplus commodities, like eggs or flour or whatever. So again, very much tied to trying to support agricultural markets. Skip forward to our rediscovery of poverty, right? This is white rural poverty, which is when John F. Kennedy was campaigning in Appalachia in the 1960s, was really struck by the extreme levels of deprivation that he observed. And in many ways, that was the impetus for a lot of our early discussions about poverty in the 60s. It became much more complex after that. But this was the time that we resurrected the food stamp program, moved it from a pilot to a program of national scale, and really Lyndon Johnson is the person who did that in 1964. And it's interesting, if you look at the actual words of what his address when he was signing the Food Stamp Act, it's a lot about our agricultural abundance, the free enterprise system, agricultural surplus, commercial food distribution, right? It is absolutely about humanitarian assistance, but it's very much framed in a lot of other priorities. Okay. Also in the 1960s, you see the emergence of food banking. How many of you interacted in some way with the charitable feeding system this summer? Food pantries, meal programs, lots of hands, right? Okay. So it first emerges in the 1960s in a formal way, and the idea is really to recapture excess food and provide it to people who are struggling, because there were a lot of people who obviously didn't qualify for federal programs, or for whom those federal programs weren't enough. And so early on, it relied a lot on donated food, especially from manufacturers who tended to have a fair amount of overrun, especially as new product development escalated, and you never knew which ones were going to stick. We always used to laugh in food banking that we always know which things didn't work because we have like every single kind of Triscuit you can imagine, the flavors that didn't sell. But the focus was really about calories, right? So early on, food banking was absolutely about meeting food insecurity needs, but any calorie is a good calorie. So a very different frame than where we might be today. And so the first program we really get that has a very explicit discussion about health and food insecurity is WIC, right? And that comes about in the early 70s. It's not that we didn't have health concerns when the National School Lunch Program and whatnot were discussed, but it was much more complex than that, and that was also tied up in agricultural commodity decision making. So WIC is that very first discussion about there are certain kinds of foods that we want young children and their moms to have, and so that discussion was fairly recent, really, in talking about hunger and health. So skip forward to the Great Recession. You don't need to read the lines. All you need to know is you're coming along, and about 2007, you get a huge spike in food insecurity. We were in the 35, 36 million. We're up to 49 or 50 million, and what's interesting is that has not abated since the beginning of the recession. What's also interesting about those lines is that food insecurity actually started creeping before the recession. Before poverty moved, before unemployment moved, food insecurity was already creeping. So I would suggest to you that it's also an early warning sign when people are beginning to struggle, because food is one of those things that is trade-offable, right? If you're tight with rent, you can always cut down your food budget a little bit. It's harder to cut down on your rent. So this is the frame we're living in now. And again, all you need to know about these squiggly lines is the bottom is TANF, which is the cash assistance welfare program we have left in this country after welfare reform, right? The very top line is the number of unemployed. Obviously, it jumped a great deal during the recessionary period. And you see SNAP is the thing that moves to respond to that level of unemployment. TANF didn't move at all. Look at this. We had really the highest levels of unemployment and underemployment we'd had since the Great Depression. This is the major cash assistance welfare program. It's virtually flat, which means that people mostly relied on SNAP as a buffer in the Great Recession. That also means that it got a lot of attention, right? Because our concerns and our worries about dependency and eroding work ethic and so on come very quickly back from our history. And so you hear Obama, the food stamp president, right? We should be happy. Not that we had the recession that we had, but we should be happy that SNAP was there and able to respond, because we know it makes a big difference. This is a great graph from the Center for Budget and Policy Priorities on the number of people in 2012 lifted out of poverty from SNAP alone, 4 million, not to mention many others for whom need was buffered. But it's become, once again, a lightning rod. We have very complicated relationships with social welfare in this country, as you know. So much of the Farm Bill, right, which takes forever to pass, and that's the other thing you should know. All of these food assistance programs happen under the U.S. Department of Agriculture, not Health and Human Services, right? They're under the Secretary of Agriculture. But food stamps was, in fact, the major fight during that, as people who were very concerned about the rise in utilization fought to try to reduce allocations for SNAP. So, meanwhile, while we're taking this tour, health in this country, as you know from last night, was changing dramatically, right? Just between 1990 and 2007, again, you don't need to know anything about these numbers, just know that orange and yellow is bad, and blue is better, and we have a dramatic change in the percentage of the population that struggles with obesity, right? So, about 1990, Mississippi had the highest rate of obesity in this country. It was about 15%, right? That's what Colorado has today, and they are the lowest obesity rate. Mississippi's upwards of about a third. So that's a huge change in our physiological existence in a really short period of time. Which means that anything we're talking about in terms of food insecurity, has to take into account that we've had a real revolution in our own health. And again, as I mentioned earlier, we don't know exactly what the relationships may be between food insecurity and obesity, but particularly for women, there does appear to be an association. And we know that some of the same risk factors that make it particularly likely for people to be obese are the same ones that show up in our list of factors for poverty or food insecurity. Things like, low income, poor education, household composition, fewer adults in the household generally means a higher level of risk, race and ethnicity, which is obviously compounded with income issues, limited access and affordability, you guys talked about that last night in terms of food deserts. You can actually live next door to a grocery store if you can't afford, you're still in a food desert, right? So it's not just about physical geography. Low cost of energy-dense food. That came out very, very clear. There's still a lot of arguments, and you guys did a great job of picking up on this about whether healthy food is actually cheaper or more expensive, but the time and the preparation and the transportation, all of those things add to cost, and you guys were great about picking up on all of those nuances. And then, probably cycles of deprivation and overconsumption that may facilitate the development of obesity and other diet-related disease and come with being food insecure. It shouldn't surprise us that the most prevalent geography where these things occur all end up being many of the same places, right? Again, dark is worse. This is food insecurity by state. This is diabetes rates, very much in the South, Southwest. Again, it happens all over the country. When you go at the state level, you don't see things like American Indian, Native American reservations where it's very profound. You don't see the urban pockets. But we're talking about many of the same communities, and I know some of you were in those communities this summer. And what does this mean? Well, if we know, or we suspect we know, that food insecurity may increase your risk of diet-related disease, and we have 49 million Americans coming out of the Great Recession and still persisting, it makes me worried about the prognosis. This is some national data that suggests that among the low-income population, not talking about the general population, among the low-income population, if you're food insecure, your rates of diabetes are higher. Now, that might go both ways, right? It might be that when you're diabetic, you're food insecure because you have more costs, and it might also be certain things about food insecurity make you more susceptible. But it's clearly an association. And this is from a colleague that I work with a lot at UCSF, Dr. Hilary Seligman, who I think has been one of the leaders in talking about the intersection of food insecurity and health. And it's a great cycle drawing about how we can imagine how these things play out. So if you're food insecure, you typically have sort of cycles of adequacy and insecurity, right? So we know on average that food insecure households are insecure about 7 months out of the year, right? But it's episodic, recurrent, but episodic. So beginning of the month, maybe better. End of the month, not so great. Certain months, seasonal employment might be helping out the family. Other months, not so good. So there are these definite cycles, and not that many people, relatively speaking, have it all the time. So you have that. What do? Of course, you eat when you've got it, and you compensate. And you also then have probably, not such great self-management capacity because you're doing what you do to survive, right? They talked about being wired for scarcity. They talked about it as if it was historical, but for food insecure people today, That's how many of them live. So then you can imagine you have poor diabetes control because you're not able to eat the foods that you should and eat regularly when you should. You get increased complications. You use more health care, right? That costs more even if you have insurance, and many people don't. That means you have more competing demands. That eats up a lot of your headspace, right? So all of this stress takes away from what you would use to parent or go to school or advance your career. And so that may increase your risk for food insecurity. And so then we're caught in a cycle that's really hard to disrupt. I think there's no substitute from hearing for people who actually live this experience. These are a couple of quotes. In the beginning of the month, I eat more meats, salads, and fruits. At the month's end, I have to eat whatever's in the cupboard. The end of the month, I start getting out of food, but I have to eat something because if I don't eat behind my insulin shot, that shot makes you so sick. I just eat anything I can find during that time just to keep me from getting sick. Right? Many people actually know they should be eating better. They just can't necessarily follow those directions. What that looks like to physicians or other healthcare professionals sometimes is non-compliance. Right? You're not following my directions. Well, I can't follow your directions, but I'm not going to say that to you. Another busy chart. Just look at the top line. This is 8 years worth of hospitalizations in the public safety system in California. The bottom lines are hospitalizations over 31 days in the month for appendicitis that's not triggered particularly by diet. The top are hospitalizations for hypoglycemia, right? Extreme low blood sugar, that's a very acute event. People can actually die from it. Look what happens in the last few days of the month. 27% increase in hospitalizations that last week. What happens at the end of the month? Run out of resources, right? They actually stagger SNAP benefits now at different points in the month, but it used to be that everybody got their benefits at the beginning of the month and you didn't have very much left at the end. That's a healthcare story, like, it's pretty extraordinary. And we see this in the clients who show up in the food banking system too. We had no idea when we did the 2014 Hunger in America study exactly how profound the health issues would be. So this is a study of 60,000 clients in food pantries, kitchens, shelters, other feeding programs. 58% of the households told us that someone in that household had hypertension, high blood pressure. Right? About a third said that they had someone in the household with diabetes. Those are diet-related illnesses primarily, right? There are also other factors that may predispose you, but that's a big part of it. 47% of clients in the food banking system describe themselves as in fair or poor health. This was before the full implementation of the ACA. 29% of those households said that nobody in the household had health insurance. And 55% of households reported some medical debt. Right? Why would we care about medical debt? Because 66% have had to choose between paying for medicine or medical care and food. So people trade off between those really basic expenses. And there are many statistics that tell the food insecurity story better than that juggling back and forth between food and other key expenses. But if you are somebody who has diet-related disease and are supposed to be taking medication, right? Choosing between food and medicine is like robbing Peter to pay Paul. It's like robbing Peter to pay Peter, actually, because food and medicine is the same thing in many instances. And so I'm guessing that many of you this summer saw hints of this. If you didn't see it directly, you saw hints of people who are, juggling, cutting one place and not the other, not following through on some things, and a lot of that has to do with very strained resources. People in low-income communities are really great at helping each other out. And sometimes that generosity also creates stresses. So when we talk to teens who are food insecure, a lot of them will talk about, oh, well, I just go over to my friend's house because I know I can eat over there if we run out of food. Well, the friend's probably not all that well off either, right? Or during the recession, a lot of people moved in with family or friends to try to cope, but more people in the household may increase food insecurity because there are more mouths to feed. So it's not that people don't help each other out and that they aren't incredibly generous. It's sometimes that those very coping strategies also increase stress. And in fact, we asked people in the charitable feeding system about some of the strategies that they used, and about half of them reported using 3 or more. Some are positive, some are not so positive, right? So for example, almost a quarter of people told us that they do grow food in a garden, at least some either in a community garden or their own. 53% receiving help from family and friends. I really regret that we didn't ask about people giving help to family and friends. That was a big oversight on our part. But we know obviously that's going on too. But what's the number one coping strategy that people indicated that they're using? 79%, and it's higher in households with children, it's 84%, report that they knowingly purchase less healthy food because it's what they can afford. And so you're going for that high-calorie sustenance, right? When you're really hungry, you are not usually dying for a salad, right? Maybe if you condition yourself to eat healthy over time, but mostly you just want some calories, right? And if you know that you have very few resources, buying things that are perishable, that you're not sure that your kids will eat, that you are unfamiliar with, that you don't know how to prepare, these are all risks, right? It's a very economically rational decision in some ways to go towards cheaper, less healthy food. And I know some of you talked last night about swamps, right? There are food deserts, there's food swamps. You go in a low-income neighborhood and everywhere you turn, there's, well, we won't name names, but, fast food everywhere, corner store. I used to drive a delivery route for HIV patients, and every once in a while the program would short us on meals, right? And I, usually went to very, very low-income neighborhoods, and so I would have to go to like Harold's Fried Chicken Shack or something, or Ribs Place, just to make sure that people got food that night, and they were like so excited that I wasn't bringing them their low-sodium meal. But that's what I had to choose from, and that was all there was. This one worries me for kids. 40% of households told us that they sometimes water down food or drinks, right? So what happens with kids sometimes is they water down formula because they don't have enough, and then that dilutes nutrients, right? Watering down juice is actually a good thing, right? But sometimes it gives us pause that you may not be getting the nutrients that you need. That's also a risk for seniors too, who have very special nutritional needs. Oh, wait, I need to go back. And I forgot to point out that about a third of people told us in the past year that they had sold possessions or pawned things specifically to afford food. So, remember I said that food making started with the any calorie is a good calorie model? The world is very, very different. And not only is it different in terms of health challenges, but it's different in how people use charitable feeding. So we used to call ourselves the Emergency Food Network, right? We still call it the Emergency Food Assistance Program, the commodities program that is providing some of the food to food banks. But it's not emergency for a lot of people, particularly post-recession. What it's become is supplementary feeding for a lot of households. We asked people kind of what their strategies were, and we were really struck by the fact that about 2/3 of the households report that they plan to get food from a feeding program on a regular basis as part of their sort of coping strategies, as opposed to just waiting when they run out. So that's a very different level of engagement and responsibility for service providers and food banks and so on when you're interacting very regularly with people around their diet. Did anybody work at a food bank? Yeah, great. Where were you? Atlanta? Right, yes, and?
I was in Richmond. Sorry, I worked
In a food pantry? Right. Just so you know, the food bank is more of the hub, and the food pantries are like the spokes, right? That's the distribution in the neighborhood. Great. So you've seen a lot of this firsthand, I think. And also the fact that it's not that food banks and food pantries don't want to give out better food. It's a struggle when you're on a donated model, right? For the same reason it is for the clients, because healthier food costs more. And if a lot of your food is donated, you may not have that much control over what's coming in the door. There's a lot going on because of this, but it's not easy. So, food banking is in the process of really taking a hard look at how it can better respond to community needs for healthier eating. We actually created sort of an inventory system for food banks to look at their inventory against what is essentially the My Plate categories. We refer to it as foods to encourage. So that food banks could really look at where they're succeeding and where they're not doing so well. Building relationships with farmers and growers. About a quarter of all the food that actually moves to the food banking system now is fresh produce. It's all those ugly vegetables, right, that we don't want to buy. It's those apples that I set aside, when I go to Whole Foods. Or it's stuff that wasn't going to make it in the market, and so I never took it out of the fields, and it used to go to waste, and now we're trying to reclaim it. Nutrition education. Several of you, I think, last night talked about trying to meet people where they were around healthier eating. It's not easy, right? It's really not easy in food banking when you have sometimes no idea what's coming through the door. So my favorite is like pumpkin season, right? Right after Halloween, all those pumpkins that you didn't buy where do you think they go? Where pumpkins go to die, they go to food banks. And it's hard to help people understand how you might use those. So you have to get really creative, and maybe actually you create recipes for pumpkin empanadas, and you sample them like they did in San Antonio. Excuse me. And then you actually move some pumpkins. But it's hard because people may not know how to use it. It's unfamiliar food. It's culturally inappropriate in some cases. And we know that culture and food and family, these are all very tied up together. Literacy, huge issue. Sometimes I look at things that go out under the guise of nutrition education, and my eyes just roll back in my head because, I can barely read them, and I'm really overeducated. And so we just don't think about how people live, or I don't own most of the cooking tools that they use on the Food Network, and I wouldn't even know what they were, right? So trying to create resources that have meaning in the way people's lives unfold is really important. And finally, developing healthcare partnerships, and I'm going to tell you a little bit about one of those. So we actually, at Feeding America, ran a 3-year pilot screening for diabetes in food pantry clients. And we really weren't sure what we'd find, and we didn't even know how people would react if you walked up to them in a food pantry line and you said, hey, can we stick your finger? And it turns out that people were actually very eager to learn about their health status. And, maybe not surprising to you, now that we've talked about this, there was a lot of it standing in the food pantry line. So we offered an intervention where we did A1C testing, that's a measure of blood sugar control over time, and monitoring 6 months of diabetes-appropriate food, both shelf-stable and produce. Self-management support and education and referral to a medical provider if they didn't have one. It's not your mama's food banking, right? That's a portable diabetes wellness van in Northern California, which was part of this project. And what we saw, at least in the initial pilot, was very encouraging. So combining food and better health support produced some really encouraging results, both in terms of blood sugar control and also a lot of other things. We were really struck, for example, in how people's depression improved without any mental health treatment. And you can imagine how if you have a chronic disease and you don't feel well and you don't feel able to do anything that the physician has been encouraging you to do, that in addition to whatever else may be going on in your life, that's incredibly stressful. So we also measured things like diabetes self-efficacy and the burden that people feel from the disease. All of those things improved. Fruit and vegetable intake, that's like the holy grail of nutrition, is to get people to eat more fruit and vegetables. And in fact, they did. And part of the way it did it was to put recipes in the boxes of food that says, this is how you use this. Here's some ideas for meals. And then people actually started taking those products and going shopping with them, or taking those recipes and going shopping with them, because it took the think work out of it too, right? I mean, I don't know about you guys, but when I get home at the end of the day, like the last thing I want to do is like plan an enormous meal and be organized, right? I'm just going to like go to the fridge and the first thing that jumps out at me is probably what we're having. So I think we underestimate how much just decision fatigue, right? Have you guys read the book Scarcity or seen the book Scarcity? You know, think this issue about how many decisions low-income people have to make every day just to get by. And so being able to take some of that out of it may help support healthier behaviors. The other thing is, wasn't a part of this pilot, I just want to mention is, you know, there's a sort of a evolving body of research around behavioral economics, or nudges. You guys know what these are? I love this because it sort of plays to the fact that it turns out we're all kind of mindless sheep. And we react to cues in our environment, and lo and behold, we do things that we don't even think about, right? Marketers have known this for a long time, right? There was no accident that when you went to the grocery store when you were little and all the cool kids cereals were like right down there at the bottom, right? Where you were short. They're still down there at the bottom for me. But we're beginning to learn how to harness this for healthier behavior. So we've worked some with David Just at Cornell. He's done some really interesting experiments. Started with school lunches because we needed to make progress in healthier school lunches, right? So they did a lot of experiments, and also in retail. Turns out if you do things like put arrows on the floor of a grocery store and you point them towards the produce section, people buy more produce. Wow, that's amazing. If you give them grocery carts and you say this half of your cart is for fruits and vegetables, people buy more fruits and vegetables because we feel the need to comply, apparently. You know, if you just make it look better, right? So if you just make it like in fancy bowls, you know, when you go to Whole Foods and everything looks really cool and inviting, even though you have no idea what the name of that vegetable is, it's the same thing. And so we're beginning to actually experiment with this in food pantries. It's a little tricky sometimes when you don't have choice, because it operates on choice and leveraging our sort of unconscious feelings when we make choices. But it's very interesting to think about that wholesale population change that we're all looking for, making healthier eating the easier choice. It turns out, though, if you hit people over the head, it doesn't work so well. So I just have to tell you, this has nothing to do with food insecurity. But somebody mentioned I think Jonathan last night mentioned the larger drinks in New York City. That was under Mayor Bloomberg. And it turns out they did an experiment at Cornell where they just invited students to do other things. And in one room, they put a big picture of Mayor Bloomberg on the wall. They didn't point it out, they just had it there. And the other, they didn't. And people in the Mayor Bloomberg room drank more soda. So we don't like to be told what to do, right? But we apparently can be led to all kinds of things. So back to the matter at hand, which is that food and medicine together can potentially be very encouraging. And so, in fact, I'm involved in a randomized control trial that's based on this project now to look at whether these results hold. So what's next? Let's take us back to the history framing, because that was very deliberate, right? We have not talked about food insecurity in this country as a health issue. very often. It's a social welfare issue, typically. It's tied up with our feelings about social welfare and our ideology and our conflicts around that. It's sometimes tied up with agricultural policy. We know that's true also on the discussions around obesity, right? Very tied up in other things. But it's been particularly pronounced in the food world. And so I guess it's my hope that we go back to what we all know, which is that you have to eat to live. If there isn't a fundamental health issue, I don't know what it is. But that means it has to be embedded in all of our conversations about health, and health has to be embedded in our conversations about food. And that's been kind of hard to do until recently. So, what's next? I'm going to skip over the SNAP debate for a minute because I want to involve you guys in that. But, so for example, increasingly physicians, and I think Sandra can talk about this, are beginning to screen for food insecurity in their doctor's offices or emergency rooms, realizing that there may be things going on with that patient that they're not aware of that's going to impede their outcomes, right? But you can't screen for food insecurity in a health setting if you don't have anything to do about it. So we have to help healthcare professionals have a solution, right? And you have to have this conversation about health in the food assistance world. And this is tricky, right? Because this is also tied up in feelings about personal choice and dignity. One of the things we do in this country when we want to change public policy is we tend to regulate the behavior of poor people. We can't make everybody behave, so we'll try to make low-income people behave. That's very tricky, right? So the fact that SNAP has been such a volatile issue has made many people in the anti-hunger world very nervous about discussions about perhaps restricting SNAP purchases only for healthier options, right? Not that they wouldn't necessarily agree that we would love to find ways for people to eat better, but often for many people, any effort to restrict SNAP is really not about health, it's about reducing SNAP. And that's a very scary place to be after we've had about 1 in 7 people in this country on the SNAP program and needing it very much. So for now, we actually have incentive programs, some number of pilots going on around the country to try to create additional incentives for people to buy more fruits and vegetables. So you've heard maybe things like double up bucks. If you spend a certain amount of your SNAP benefits on fruits and vegetables, you actually get bonus amounts, more that you can purchase. I don't know where this is going to come out, and it's not going to go away. And is anybody here from Kansas? No? So Kansas is in particular really focused on this right now and has been having a lot of discussions at the state level, which may or may not hold with the feds, but about, we don't want you to buy lobster with your SNAP benefits. We don't want whatever, steak. Overlooking the fact, frankly, if you live in Maine, lobster might be an incredibly cheap protein in certain parts of the season. So, again, we get hung up on these issues about deserving, undeserving, how you're using my tax dollars. Of course, my tax dollars are also paying for many well-off, higher income people who have all kinds of medical complications from obesity, right? Don't talk about that so much. It's very easy to default to regulating low-income people, and that's something that you guys will, I hope, really be thoughtful about, because we have to make some changes, but all of these conversations come with risk. So, I'd like to just leave it with you all for a few minutes. Did you observe intersections of hunger and health issues this summer when you were out working in the field? Did any of this resonate with you? You thought, oh, I saw that. That reminds me of something. Yes, in the orange?
Yeah, I was working with the Kansas Coalition of Healthcare Providers.
Hold on one second. I'm going to make sure I get you your mic.
Thank you. I was working with the Camden Coalition of Healthcare Providers. My name is Michael Sullivan. I'm a student at Washington and Lee University. And me and Tierney worked at the Camden Coalition of Healthcare Providers, and we were doing a patient satisfaction survey in waiting rooms of primary care practices and hospitals and things like that. And they changed something on the survey this year where at the end of the survey we asked 2 questions related to food insecurity to try to find some data about food insecurity in the city of Camden, for which there is no data set. They only do Camden County, but that has a very different demographic and things like that as opposed to the city. So we got a chance to really kind of analyze that data and found some pretty startling amounts of people who are reporting that they found the exact statement that was on the slide was always true or sometimes true, and things of that nature.
It's great. Yeah, Camden has really been out in front in trying to struggle with these issues. So that's awesome that you had that experience. And this is exactly what we would hope to do, is that you could go, there's a 2-item version of those questions, and that's the screener that a lot of people use in a clinical setting. And I do think people are really startled. There's an interesting article, it took place at a pediatric training program, I think it was the University of Cincinnati, where they asked residents to estimate how many of the kids in a primary care clinic were food insecure, right? This is a public safety net. It's not, you know, it's not all kinds of income levels. And they said about 2 or 3% is what they thought. Well, they knew from other data it was more like 28%. So the physicians were not catching it, and that obviously could have profound implications for health, right? Okay, in the middle. Just wait for the mic.
So Alana and I worked in Greensboro, North Carolina with the Mobile Oasis Food Project, bringing healthy produce into food deserts in Greensboro and High Point. And one of the things that I thought was really interesting, we haven't gotten to experience it yet, but hopefully we'll get to go back and visit. They're starting a market currently they'll have 5 markets going, and one of the markets will be at the hospital, and doctors are going to do prescriptions for produce, which I think is really cool. So they're tailoring people's diets to their health issues, a lot of like HIV patients and diabetes patients and that sort of thing, which is really cool. And then the other thing that we focused on a lot at the market was health education. We worked at the health education table, and I was really impressed with how many people came up to us and said, oh, I have type 2 diabetes. How can I help control this using the produce available to me? I have cancer. How can I eat better for that? That sort of thing. So that sort of resonated with me.
Perfect. And that's that is the intersection of hunger and health right there, right? And one of the things that, I think we see is that often if people are told by a physician or other healthcare provider, this is something you need to do for your health, you need to see if you can sign up for SNAP because it's good for your health, It's good for your kids if you can sign up for these programs. It's good for you to connect with these programs. We haven't had that conversation, right? And we haven't had it the other way, right? Food banks have clearly been looking at folks struggling with all of these health issues for a long time and not being a primary place where you could connect people back with healthcare that they desperately need. So thank you for that. On this side, yes? I think there's a mic on that side, yeah.
So this summer I worked in DC, and I mentioned this last night that I did this healthy living program. And something interesting is I came across a program that's been apparently very successful that was a prescription program. So you would go in and talk to your doctor, and they would see that you're, malnourished. And so they would give you a prescription. You could go fill it at any grocery store in the city or farmers markets. So I thought that was a really cool, successful program that I'd not heard of before. But also, there was a farmers market collaborative that was started, and that my program became a part of through the summer. And what it is it provides people the opportunity to go to farmers markets, and we let them know that these farmers markets accept WIC and SNAP benefits. So that way, when you're at farmers markets, you're only surrounded by fresh, healthy, for the most part, food. And so it was a way of bringing the options available, showing people that you can have access to healthy and cheap food.
Which is great. I mean, that was a barrier early on to using farmers markets, was a lot of them didn't have that technology, and that's really shifted. I think farmers market movement is awesome, That being said, most people don't shop in farmers markets and probably aren't going to make a wholesale shift, particularly if you live where I live in Chicago in the winter. So we need it to permeate retail, period, right? And that I think is the next frontier. But the farmers market folks have really kind of led the way and showed why it can be compelling. Yes?
So my name is Lydia, and I worked in Richmond with a children's summer camp. And in designing the programming for the summer, one of the things that we knew that we had to do in working with these children was providing them with breakfast and lunch. And because we know that a large number of these families are food insecure families, and it became a big selling point for the program. So when we walked up and we went around signing up, knocking on doors, and we would explain what the program is, it's free, we provide transportation, they were still pretty hesitant, but then when we let them know, when we give them food, then that's when the families were more interested in the program because now it had a purpose. So.
Absolutely. I think, again, it's very hard on families summer, right? There's so many kids who use school lunch and the school breakfast program on a free or reduced price basis. And then the number that take advantage of the summer food service program, which is also available, is so much lower. And so any effort, right, to do that. We see food insecurity go up in the summer. We also see obesity go up in the summer, right, with kids. Summer is our real danger time. Yes?
Wait, can we just wait?
Yep.
There's going to be a lot of time yet to ask Elaine questions, so maybe we should move along.
Okay, great.
Thank you
Thank you so much.
I think they keep asking all day, and I'll get them to ask later.